All right. Hi, my name is Jessica Smith, and my parasite seminar is on Entamoeba histolytica. Before we get into the actual seminar, this is just a brief outline. So I'm going to briefly talk about taxonomy, some historical facts on Entamoeba histolytica, including some statistics on amoebiasis, amoebas in general, and then finally getting into the meat of it. So Entamoeba histolytica life cycle, pathogenesis, diagnosis, and treatments, along with cases related to that. And then finally ask my 2 questions at the end. So when I was researching the taxonomy for Entamoeba histolytica, I got like several different types of taxonomic classification. So this is the one I got from a government source. Notice how it says like the kingdom is protozoa, but then when I looked up another government source, we have like super kingdoms, clades not super identified. And then of course, I think most people start off with the Wikipedia, which I did just to double check, just to see, with the grain of salt, of course. And again, the purpose of showing these different taxonomical classifications is just to emphasize that protists in general are very, very hard to classify because of all the different characteristics, molecular traits, and so on and so forth. So just emphasizing that scientists are still going through that process. And where does it fit? Are we still kind of confused on why there's so many different taxonomical lists? That's okay. Scientists are okay with not knowing everything about a specific group. Let's get into some quick historical facts on Entamoeba histolytica. Some of this might be a bit of redundancy, but that's okay. So it was first discovered in 1875 by Fyodor Losch. He was a doctor looking at, and he had a patient. And this was the first proven case of amoebic dysentery, and it was in St. Petersburg, Russia. Keep in mind that this is when discovered in the sense of like a parasite is causing dysentery. Not to say that dysentery wasn't caused by parasites before. This is just like the first discovery of it. He originally named it Amoeba coli. However, Fyodor Losch did die due to amoebic dysentery. Later down the road in 1903, that name was changed to Entamoeba histolytica in 1903 by Fritz Schaden, who was a zoologist. He also did experiments on Entamoeba histolytica and also died due to amoebic dysentery. I just thought that was a little ironic. Moving on to more studies with the parasites. In 1925, Emil Brumpt, when he was studying it, he suggested that there might be 2 species. From there, in 1969, the World Health Organization defined amoebiasis finally as an infection with Entamoeba histolytica with or without clinical manifestations. And then moving on to Diamond and Clark in the 1970s, went and revisited Brumpt's hypothesis. And in 1993, due to technological advancements such as biochemistry studies, molecular studies, and genotyping, new data went ahead and supported that hypothesis that there was 2 species. And so in 1997, the World Health Organization, had a meeting in Mexico City, led to clear guidelines distinguishing that there are 2 species, Entamoeba histolytica, which is pathogenic, and Entamoeba dispar. And I'll talk more about the different species in a little bit. But just understanding, and I wanted to add so much more because this like specimen is very interesting, not just like the pathogenesis, but also historically how it's been studied. And yeah, moving on. So amoebiasis, so the actual disease caused by Entamoeba histolytica. So let's just break that down. What is Entamoeba histolytica? Like breaking down what that is, what the actual words are. So ent meaning internal, amoeba meaning amoeba or amoeboid, histo meaning tissue, and lytic meaning lice. So this is an internal amoeba that you can find this amoeba within your body internally, right? And it lyses tissue. It kills more than 55,000 people each year. It's endemic to developing parts of Central and South America, Africa, and Asia. So basically like the tropics or subtropics. And it's not to say that it's everywhere, but usually in places where there's inadequate hygiene and inadequate access to sanitation. And of course, travelers are at risk. So travelers who go to these places such as South Asia, the Middle East, South America appear to have the highest risk. So again, earlier I stated that protists have a very diverse, they are a very diverse group in general, and it's very hard to classify them. Most people, though, when they think of amoebas, they think of this guy right here on the left, the pink guy, and that guy is Amoeba proteus. So the genus, when we think of amoebas, we're thinking of the genus Amoeba. It's not to say that these guys aren't related, right? They're related through this big superphylum Amoebazoa. So there's that connection. But amoebas overall, again, even amoebas within themselves have their own very diverse, their diverse group. And so just wanted to add a couple of like cute little gifs. I didn't even know that slime molds were part of amoebas until I started researching this parasite. Not that this parasite is a slime mold, but just kind of showing that, again, just how diverse each group is. So briefly, I just want to briefly talk about the morphology of amoebas, just more specifically generic, even though there are different shapes, different morphology to amoebas. I just want to start with a very generic morphology diagram. So here we have the food vacuole, we have a nucleus, we have an endoplasm, an ectoplasm, and then of course the pseudopod, which is very distinct character for amoebas. And of course, there are different kinds of pseudopodia. So we will look more at that later, hopefully in future lectures, or not already if we haven't looked at it already. And again, this diagram is Amoeba proteus. So, but looking at the relationship between like the features for these two separate species, but still part of that superphylum, right? We see a pseudopodia, a food vacuole, there is a nucleus, an endoplasm, and an ectoplasm. So same distinct characteristics. Not everything is exactly the same, but the same traits that you would find in an amoeba. Moving on to the life cycle. So we know from lecture and from the lab that Entamoeba histolytica has two stages, specifically the trophozoite stage. So we know that this is the trophozoite stage just by looking at the size and the ingested red blood cells. This is just my picture that I did for lab, and I just kind of wanted to it was already labeled. And knowing that there is a nucleus with the kerosome right in the center. And then, of course, there is the cyst stage. So we have a mature cyst, and we can recognize that by the 4 nuclei, or we can have an immature cyst recognized by 1, 2, or 3 nuclei, with the chromosomal body being the distinct character, knowing that it's a cyst. And I'll talk more about characteristics for differentiation later down the road. All right. I have a video that I'd like to share. It's a really great animation. It is in Spanish, so I do have some of the translations written down for those of us who probably don't know Spanish. So this animation already has us right in the large intestine, so the mucosa, and we could see the microvilli right here indicated. And this is where we're going to find these guys as far as like if somebody was infected. Most of the time, but we'll get into the pathogenesis in a moment. So here we have a cyst, and we know it's a mature cyst just by looking at the 4 nuclei. And then also surrounding it itself is the hyaline cyst wall. And that hyaline cyst wall is very, very strong in combating different environments. And so what happens is it goes ahead and dissolves or excises itself, right? And then it gets ready to divide. So it's going to divide itself into 8 new trophozoites. There's no music to this video, which is kind of sad, but hopefully me talking over it makes it a little bit more exciting. And so we know that during the trophozoite stage, this is a stage where it can actually move. And so for it to be moving, right, it's also going to want to feed. And so the way that it feeds through phagocytosis. And so it'll ingest bacteria. And then, of course, earlier we talked about it ingest red blood cells. So again, it travels throughout the nucleus. And notice how there, and again, this is just an animation, but notice that there is contact between the epithelial, the microvilli. And then we know that trophozoites can either make more trophozoites through binary fission. And so it's going to do that right now in this animation. And then I'm going to speed this up a bit. So we know that trophozoites can make more trophozoites via through binary fission, or it can go ahead and make more cysts. And so we start off with the hyaline wall forming again. We have nuclear division going on and the chromosomal bodies, indicating that it's an immature cyst. And then further development, we get to the 4 nuclei, a full cyst wall, and then it starts all over. So I'm going to just go over that again very briefly, and I'm going to use these drawings that I have for the purpose of this animation I'm about to go through. And again, these are not drawn to scale. So again, we have either the cyst stage or the trophozoite stage, and dependent upon how the trophocyte is going to multiply itself, whether either binary fission making more trophozoites or making more cysts. However, when we take in Entamoeba histolytica, as far as like us getting sick, the thing that gets us that infective stage, if you will, is going to be the actual cyst, the mature cyst. And so we ingest this cyst either via anything that's been fecally contaminated and putting it into our mouth. So food, water, and anal to mouth sexual activity. So from there, the cyst gets ingested. And the reason why I pointed out the hyaline cyst wall as a very protective, it can survive outside of the body for weeks or months. And it also can survive our stomach content. So our very, very extreme environment that's within our stomach. Trophozoites cannot survive that long outside of the body. And so I wouldn't assume that'd be able to do so in the stomach. So we ingest a cyst and it finally reaches our colon. And so from there, it's going to go ahead and excise itself. And again, these are not drawn to scale. This is just to hopefully give a more clearer image. The trophozoites are going to go ahead. They're going to move around. They're going to feed. They're going to cause some issues with the epithelial cells, but we'll talk about that in a moment. So they go ahead and feed. And again, they'll either make more trophozoites or more cysts. And so those cysts either become mature, and they go ahead and exit out of the body, and the life cycle starts all over again. But now we need to talk about pathogenesis. So again, how is it that this parasite hurts us, right? How is it that it causes a disease to us within inside our body? So again, that cyst goes and travels to our intestine. And we're going to zoom in a little further. Okay, so overall amoebiasis, think of it as inflammation caused by an amoeba. So let's start off with intestinally what's going on. So it gets there, it excises itself, and the way that it causes harm to us, at least at this point in time, are 2 ways. It causes inflammation and it causes cell death. For inflammation, what it does, it sends out proteins inflaming the epithelial cells. Now, when this happens, our immune system is going to want to respond. And so it's going to send white blood cells, more specifically neutrophils, will go ahead and try to mediate this inflammation. And what it does is it sends out oxygen-free radicals. Okay, I know there's a lot going on in this picture, but just understand the amoeba will go ahead and send out protein that inflames the tissue, which is here. Our immune system, our immune cells are here. and it sends out oxygen-free radicals to basically stop that from happening. The problem though with that, and this is why parasites are really, really good at why they're parasites, right? You are using our immune system against us. And so not only is it hurting the Entamoeba histolytica, but it's also hurting our epithelial tissues. It's causing collateral damage. And then another way, again, is cell death. And what it does is the Entamoeba histolytica can also have cell-to-cell contact with our epithelial cells. There's a study that I was looking into that they're doing more research in. It's called tragocytosis. And all that means is the Entamoeba histolytica is taking like little bites. It's not fully ingesting the epithelial cell, but it's taking little bites. And that stress on that cell is causing that epithelial cell to go into apoptosis or cell death. So just even more damage to the epithelial cells. So dead cells all around. So that's intestinal amoebiasis. So one last thing as far as like pathogenesis. So invading the rest of our body, which gives us extraintestinal amoebiasis. So let's say that it's gone ahead, it's done quite a number of damage to our epithelial tissue. It's going to go ahead and now go through there because now there's an opening. Now it is passed through. There's enough room for it to go through. And then it's going to go ahead and travel using our bloodstream, using our veins, and travel to different parts of our body. So it can travel to the liver, causing hepatic amoebiasis. It can travel to our lungs, causing pulmonary amoebiasis. And even in extremer cases, it can travel to our brain, causing cerebral amoebiasis. So symptoms. You as a person, right? What you could probably feel and what the doctor will probably tell you if you have it. This is what I'm going to go over. So symptoms would include, you could be asymptomatic. You can have the parasite and feel absolutely nothing. Gastrointestinal symptoms are going to include diarrhea, bloody stools, weight loss, abdominal pain, colitis, which just means inflammation of the colon, and ulcers within your colon. This is just for intestinal amoebiasis. And there's two types of infections when you have amoebiasis. It can be intestinal or extraintestinal. Extraintestinal meaning outside the intestines. So extraintestinal symptoms, if it's affecting the liver, you can have liver abscess, fever, right upper quadrant pain, abdominal pain near the liver, jaundice. So for anyone who doesn't know jaundice, that's just discoloration of the skin. And because, right, the parasite is using our bloodstream, using our veins to get to the liver, you can also cause issues for our heart. So a cardiac infection, which can cause inflammation in the heart and fluid buildup. Other extraintestinal symptoms, if we're talking about our lungs, we have fever, coughing, respiratory distress, and even partial lung collapses. And then for our brain, we'd have brain abscess, which could be causing headaches, vomiting, mental status change. So our brain helps us with a lot of our functions, specifically like in our mood and the way that we either talk or move. So any changes in that are prohibiting, like things from us moving can cause changes in that based upon our damage to the brain. All right, moving on to diagnosis. Earlier, when I talked about the historical facts about Entamoeba histolytica, talking about like how it was difficult to determine the difference between histolytica and dispar. So morphologically, histolytica and dispar are very, very similar. It's very hard to be able to detect them just by looking at it via the microscope. And sometimes it's even hard to detect the other types of Entamoeba. So earlier in today's lecture, if you looked at it already, Dr. Verduri talks about coli and Hartmanni, and I believe Mashofsky, talking about, you know, what are distinct characteristics to differentiate between each other, right? So for histolytica, these are morphologically similar, but to differentiate between the other ones like coli and Hartmanni, you would look at the number of nuclei. So for instance, 4, we would only expect to see maximum of 4. And we'd also look at the chromosomal body. What type of shape is it? for us to differentiate between these types versus these types. So how do we differentiate within histolytica, dispar, and Moshkovsky? Well, because histolytica is the only pathogenic version of this, right? We would see if there are red blood cells, ingested red blood cells in the trophozoite stage. And that helps us be able to diagnose that, hey, that person has the Entamoeba histolytica. Right. So most of that, what I just described was microscopy, which great thing about it, it's widely available, minimal equipment. The problem is it's hard to differentiate between species. And so with technological advancement, however, we're able to differentiate between different Entamoebas. So we have stool antigen detection, which helps us differentiate. We can also do blood tests. It's not necessarily good at differentiating between species, but it can tell us if there is amoebas within our blood. You can also run a PCR or molecular studies. It is expensive in places where, like the developing countries, they may not have easily access to it, which is probably one of the reasons why it's still prevalent within those areas. Of course, socioeconomic issues, but that's a separate story. And then we can also do colonoscopy, which it's not necessarily in the case of like looking to see if you have Entamoeba histolytica, but looking for symptoms that are caused by Entamoeba histolytica. So looking within so a colonoscopy, you're just shoving a camera through your colon and looking to see if there are any ulcers. And if you have certain ulcers, that can lead you towards you might have a bacterial infection, or maybe it's a parasitic infection. Treatments for Entamoeba histolytica, the biggest one in all of my case studies is metronidazole. It's an antibiotic, but it's also an antiprotozoal. So useful against some protozoans, useful against amoebas, or excuse me, Entamoeba histolytica. It's usually the first line of defense. Depending on how bad you are infected, most of the time you are also prescribed a lumen agent, and that's just helping support the lumen, right? Entamoeba histolytica does a lot of damage to our intestine, and so it just needs that kind of like extra support. So remember the collateral damage done by the oxygen-free radicals and the amoeba itself. And then another more hands-on approach would be surgery and drainage. Sometimes surgery and drainage is used if the metronidazole wasn't thought of first, or if it's unavailable. Okay, I know that was a lot. Hopefully it's sticking. Hopefully it's making sense. And now we're going to get into the case studies. All right, so our first case study is in Japan. And so I'm going to be talking about, for my first case study, intestinal amoebiasis, which again is a amoebiasis happening within the intestines, nowhere else. All right, here is our patient. She's a 41-year-old female. She's HIV-1 negative. And the only reason why I'm adding this is because I believe we did briefly talk about it in lecture and some of the other papers that I've read. It's not always the case, right? But having HIV, there's some studies show that there's a correlation between Entamoeba histolytica and also having HIV as far as like what I was looking at. So that's the only reason I'm adding it. The patient was also a commercial sex worker. And again, this study was done in Japan. Her symptoms included watery diarrhea, and this was more than 10 times a day. For this particular study, the person was actually infected twice. For the study itself, as far as like what they were able to document, mostly was when the patient was infected the second time. So I just want to emphasize that this person was treated twice for amoebic colitis because they're infected twice. So for the first time that they were infected, the tests. So at first, the patient was given probiotics. Most of the time, in this case, especially in all the studies that I'm presenting today, all the doctors immediately think it's a bacterial infection when they look at the symptoms. So person was prescribed probiotics. That didn't really help. And then from there, later on, they did a colonoscopy, a biopsy was done. And within the colonoscopy, they saw ulcers that were identified, and a PCR was ran, and it identified that it was Entamoeba histolytica. Treatments that were given was, of course, metronidazole. And they also did a 1 to 2 month stool check, running PCR again, and it showed negative results for the parasite. The doctors recommended to do a follow-up colonoscopy. However, the patient had declined. And no lumen agent was given for the first treatment. Now, this is for the second time that the person was infected. So this is the pictures here, and we can see the ulcers clearly within the infection of the cecum, the colon, right? All indicated in the pictures. So it wasn't until 10 months later, after the first treatment, right, looking at it and seeing that it was negative, right? This was 10 months after the fact. When they wanted to do the follow-up colonoscopy, they wanted to do it a month later. But again, the patient had declined. If I'm remembering correctly, I believe they were really pushing to do a follow-up, and finally the patient finally agreed to do a follow-up, again, but 10 months after the fact. A follow-up colonoscopy was done, and it indicated mucosal ulcers, again, as shown here in the pictures on the right. So at this point in time, the patient, again, who was being pushed to do a follow-up, was asymptomatic. 7 days after the colonoscopy, however, the diarrhea had came back. And a PCR was ran again, and it was positive for Entamoeba histolytica with the same genotype. So indicating that the person got the infection from the same source. Treatments. Again, metronidazole was prescribed, this time also with a lumen agent. And then a final colonoscopy was done 4 months later after the paramomycin is just the lumen agent. And just to, again, confirming that the ulcers had finally cleared and healed. One cool thing about this study was that they not only looked at the patient and how the infection, affected their body and the treatment, but they also collected stool samples and looked at the bacteria within those samples. So as we know, our body, right, we have excuse me, we have a symbiosis, a mutualism between our gut microbiome, excuse me. And so this led them to look at different stool samples at different points in time. So they took a stool sample before the metronidazole. They took one after metronidazole, but before the lumen agent was prescribed or was taken. They took a stool sample after everything had been done, so after treatment and after the colonoscopy. And then they took one just before the colonoscopy, but after the bowel cleansing. So I don't know anybody who has had a colonoscopy, but to my understanding, prior to doing the colonoscopy, they want you to do what's called a bowel cleansing. So, I believe you have to eat soft foods, just making sure that when they do the colonoscopy, that it is pretty much clear. And so from this, they saw that samples A and D were very similar, showing an invasive stage, and samples C and B were similar in the sense of showing an asymptomatic, and that these two types of the samples were different. Again, I'm just pointing this out, just as scientists, we always, when we're doing research, it might lead us to more questions. And from those questions, we can look into more studies and investigate more connections. And so I just wanted to throw that in there because I thought it was interesting how they were trying to, and they looked at other studies too, to see some correlation between your gut microbiome and Entamoeba histolytica and probably other parasites that infect you internally. So I just thought it was interesting. Okay. So based off of everything, possible causes. For the first infection, the most likely is anal to mouth sexual activity, just based off the background that the patient is a sex worker. As far as the second time around, it's possibly unsure. So here are just a couple of things. One thing that the authors pointed out is that probably from the bowel cleansing. So when you do a bowel cleansing, you're also decreasing your gut microbiome. So maybe because the gut microbiome, again, that's like one of the extra steps that they were doing for further research, indicating that, maybe a gut microbiome is, giving more room for that parasite to go ahead and continue causing damage. It could be that maybe the patient didn't take the metronidazole treatment. I don't know about you guys, but, some people, any sort of antibiotic, and the doctor tells you, hey, make sure to take it all the way through, take it 3 times a day for 10 days straight. And by that 3rd day, you're starting to feel great. And maybe you're like, I'm feeling great, so I don't feel like I want to take the antibiotic. Take your antibiotics as far as like what the doctor prescribes. If you have a deadline, take it all the way through to that deadline. So that's just my hypothesis that I came up with as far as like a possibility, because they didn't want to do the follow-up. So maybe because they thought they were feeling better, or it could just be the same source as far as like, anal to mouth sexual activity, maybe the same partner or whoever is infected. Suggestions for prevention. So preventing from getting Entamoeba histolytica, just based off of this case. Understanding that even though it's more likely if you're, in a male to male sexual relationship, as far as like, I'm not a male, I like male to male. What I'm getting at is it's not just for homosexuals, it can also be transmitted heterosexually. So just practicing safe sex in general. Encouraging and informing your partners to get tested and treated, and always do a follow-up with your doctor. All right, moving on to case study 2 in France. And this case study is hepatic and intestinal amoebiasis. So hepatic meaning outside of the intestine, but this person also had intestinal amoebiasis. So the patient was a 67-year-old Frenchman. He was retired from public service. He was on hypertension meds, had a female partner. He had never traveled outside of Europe. And again, this location for the study was in France. His symptoms had, at the hospital, he was admitted for liver pain and fever. 6 months before, he had bloody diarrhea, and he was having upper right abdominal pain. So tests and diagnosis. So 6 months prior to being hospitalized, like I said, he had the diarrhea. However, 3 months after his diarrhea symptoms started, that's when he finally went to his general practitioner. The general practitioner obviously tested for if it was a bacterial infection. It came back negative. He was still given an antibiotic, and of course, this did not help. Hospital tests, once he was admitted, blood tests, and when you're looking at when your blood is being tested, obviously it's being tested for a number of things. As far as like in relation to this disease, I've included these tests in relation to the blood tests. So a high white blood cell count, very, very high, and again, mostly neutrophils, and high C-reactive protein, which again, this is an indication that there's inflammation happening. So we have a lot of white blood cells going on. We have diarrhea. We have inflammation. And so from there, because of that pain, probably they wanted to do a CT. So an abdominal and pelvic CT was done, and it indicated 2 hepatic abscesses and signs of chronic colitis, which again is just inflammation of the colon. From there, they took fluid from the abscesses and tested it. They ran a PCR, and it was positive for Entamoeba histolytica. They also went ahead and did an amoebic serology. Serology is just blood work. And that also tested for intestinal and hepatic amoebiasis. Here's a couple of pictures. So this is the abdominal CT scan, and you can see that it's showing 2 cystic abscesses cavities, and just the difference between an abscess and an ulcer. It has to do with, I believe abscess is like, if I can remember, God, I just looked at it. It was like external or enclosed, where an ulcer is a more open infection. Abscess is an enclosed infection, if you will. So we have the cavities here indicated on the scan. Here is an abdominal CT, and it's showing the inflammation indicated here in the black. And then this one's just an overall of the entire abdomen. And again, our liver is here, and so our intestines would be right around here. And we see the abscess here and the inflammation here in the scan. So again, as far as like figuring out diagnosis, because this patient had a lot of tests, and I like excluded some out because it just was showing normal ranges, normal results, right? The way of thinking, right, and I'm assuming for most doctors too, is most of the time when you probably are coming into the doctor for these type of symptoms, their first instinct is probably going to be it's probably a bacterial infection. And so this was their train of thought as far as like differential diagnoses. So they started off thinking a bacterial abscess caused by the digestive tract infection, which then, okay, well, we're seeing that he's having upper quadrant pain. So maybe it's infectious via endocarditis, which is just inflammation of the heart. And then finally leading to the diagnosis of Hawaii. It's definitely parasitic abscess based on all the tests, all the data we've collected from the tests. So treatments, metronidazole was prescribed, followed by, I cannot pronounce that, but this is just another anti-protozoal included with the metronidazole. A follow-up was done. There was no reoccurrence of the ulcers, and the stool samples were tested for negative. So where the heck did it come from? Where did the disease come from? Well, the study said that the parasite came from the patient's female partner. She had traveled outside of Europe. He had not, but she had, and she had traveled to the endemic areas, including South America, India, Burma, Vietnam, and Laos. She, however, was asymptomatic. So they tested her blood and it was positive for parasites. There were no abscesses shown. She was given the same treatment as the patient, and her amoebiasis had cleared up. So suggestions for prevention based on this case. Again, always practice safe sex. Encourage and inform your partners to get tested and treated. One extra thing is anytime you travel outside of the country, it's probably best to get tested for diseases when you come back. And just having a symptom of chronic diarrhea, this was indicated by the researchers, and I agree with this. Just having a default parasite testing be done for anybody that's showing symptoms of chronic diarrhea, regardless of if that person has traveled or not. All right, our last case study leads us to Turkey. And this case study is on cerebral amoebiasis, so amoebiasis within the brain. So patient background, it was very, very small. It was an 11-year-old girl that had cerebral palsy. And just as indicated by the CDC, it's just basically a person's ability to move, maintain balance and posture. And this is caused by abnormal brain development or damage to the developing brain. It's just a culmination of disorders preventing you from, the balance, the posture, the movement, because something's wrong with your brain. So, however, because she had cerebral palsy, she was able to do the following: make eye contact, smiling, and even so much as handshaking. So her symptoms: she had progressive drowsiness, diminished movements of her upper limb, swallowing problems, and all of these 3 symptoms were going on for 7 days prior to being admitted to the hospital. The tests, so pre-diagnosed with encephalitis, again, most of the time when we're showing specific symptoms, dependent upon what's most common, our doctor is probably going to go to what's most common disease based off the symptoms. So in this case, inflammation of the brain. That's what just encephalitis means. They went also ahead and did a physical examination testing for verbal stimuli, which she was unresponsive. However, painful stimuli, she passed by trying to avoid, and in the sense indicated by her flexing. Blood test was also done, and again, just indicating a high white blood cell count, mostly neutrophils, inflammation based off of the high C-reactive protein, and then high erythrocyte, which is just blood cells. So sedimentation just means more blood cells being pumped out, which would be causing inflammation if there's too much. An EEG was performed, and it wasn't showing any epileptic activity as being the cause. They did run an MRI, and it showed multiple abscesses. And here's a picture right here of the MRI scan. So there are abscesses. They needed to drain that immediately. So they did a surgical drainage. And from that surgical drainage, they were able to see many leukocytes, which is just white blood cells. And then they were able to look at the cells indicated here by the arrows, just by looking at the morphology and the ingested red blood cells. They were able to identify that as Entamoeba histolytica. Just looking at it morphologically, not running any blood tests, but just looking at the morphology on the microscopic slide. And then here's just another picture. So, treatments. The patient was given metronidazole intravenously, so just like an IV of metronidazole. This was done for 6 weeks with 3 weeks in the hospital. The doctors had planned to do another surgical drainage, however, the family refused. So they went ahead and switched to just oral metronidazole for 2 more weeks. The treatment had ended, and the patient had regained pre-existing abilities such as smiling, handshaking, etc. And then they ran another CT, and it showed no signs of recurring infection. Causes based off this case, it's quite uncertain because there wasn't any additional information given on the patients. So these are hypotheses that I came up with. The parents possibly have traveled, or depending on where they live in Turkey, right, what their living situation is, maybe it's an unclean, no access to sanitation as far as like a possibility. Suggestions for pathologists based on this case, because again, I can't really make suggestions as far as like us to prevent to get through this based off this case, only because like there were no other, we don't know the cause. But for pathologists, just include automatic testing. This is just me. Just include automatic testing for parasites, not only just test for bacterial, and like if it's a bacteria causing the disease, just automatic. Find a default for also seeing if it's a parasite causing the disease. And then of course, making tests more accessible. So tests that helps narrow down the diagnosis of the disease more thoroughly, such as serology tests and PCR tests. And then here are my sources. And then finally, our questions to think about. So question number 1, right? Why were multiple tests or diagnostics done for the 67-year-old man? So basically, why did it take so many tests to confirm that it was amoebiasis causing the disease, or excuse me, amoebiasis as the disease? And then question 2 would be, what are possible reasons for the sex worker patient contracting amoebiasis twice within a 10-month period? And that's it.